Your mother has been forgetting things lately. She repeats the same questions. She can't remember what she ate for breakfast. She gets confused about what day it is. You're terrified it's Alzheimer's. You schedule a doctor's appointment, fearing the worst. But what if I told you that her confusion isn't dementia at all? What if it's caused by one of the 11 medications sitting in her medicine cabinet right now? Medications her doctor prescribed. Medications she takes every single day, trusting they're helping her, when in reality they're systematically destroying her cognitive function. I'm Dr. Trask. I'm an anesthesiologist, which means I see patients before, during, and after surgery. And I've noticed a disturbing pattern. Seniors come into the hospital mentally sharp. They undergo a procedure. They're given certain medications for pain, sleep, or anxiety. And within days, they're confused, disoriented, unable to recognize family members. We call it post-operative delirium. But here's what I've learned. Many of these patients were already taking medications at home that were quietly eroding their cognitive function. The surgery just accelerated what was already happening. Today I'm going to reveal 11 medications that are strongly linked to dementia-like symptoms in people over 60. Some of these are prescription, some are over-the-counter. All of them affect your brain in ways that mimic or accelerate true dementia. And the tragedy is that when you stop these medications, cognitive function often improves dramatically. The dementia wasn't permanent brain disease. It was drug-induced cognitive impairment that everyone assumed was just aging. You need to understand something critical before I reveal these 11 medications. Your brain after 60 is fundamentally more vulnerable to medication side effects than it was at 40. The blood-brain barrier, which protects your brain from toxins, becomes more permeable with age. Medications that couldn't reach your brain tissue at 40 can cross into brain tissue at 70. Your liver and kidneys, which break down and eliminate medications, function at 60 to 70% of their younger capacity. Medications accumulate. Doses that were safe at 50 become toxic at 75, and your brain has less reserve. Neurons you've lost over decades can't be replaced. When medications interfere with the neurotransmitters your remaining neurons need to communicate, you don't have backup systems to compensate. Cognitive function declines rapidly. And if nobody recognizes that medication is the cause, the decline gets attributed to dementia. Medications are never stopped, and the person continues deteriorating. Now let me reveal the 11 medications, and I guarantee at least 3 of these are in your home right now. Number 11, diphenhydramine, Benadryl. Diphenhydramine is the active ingredient in Benadryl. It's sold over the counter for allergies, itching, and sleep. Millions of seniors take it regularly, assuming it's safe because it doesn't require a prescription. But diphenhydramine is one of the most dangerous medications for brain health in older adults. Diphenhydramine is strongly anticholinergic, meaning it blocks acetylcholine, a neurotransmitter critical for memory and learning. When you block acetylcholine in an aging brain that's already producing less of it, cognitive function crashes. Confusion, memory problems, difficulty concentrating, these appear within days of regular use. A landmark study published in JAMA Internal Medicine followed over 3,400 adults over age 65 for more than 7 years. Those who regularly used anticholinergic medications like diphenhydramine had a 54% increased risk of developing dementia, 54% E4. And the risk increased with cumulative exposure. The longer you took it, the higher your dementia risk. What's particularly insidious is that people take diphenhydramine for sleep, not realizing it's causing the very cognitive problems they fear. They wake up groggy, confused, unable to think clearly. And instead of recognizing this as a medication side effect, they assume it's dementia starting. The medication that's supposed to help them sleep is destroying their brain. If you're taking diphenhydramine regularly, stop. For allergies, use second-generation antihistamines like loratadine or cetirizine that don't cross into the brain. For sleep, address the root cause of insomnia through sleep hygiene, cognitive behavioral therapy, or safer medications that don't have anticholinergic effects. Number 10, amitriptyline. Amitriptyline is a tricyclic antidepressant that's been around for decades. It's still prescribed today, often for depression, nerve pain, or migraine prevention, and it's one of the most anticholinergic medications in existence. Taking amitriptyline after age 65 is like pouring sand into your brain's machinery. The same JAMA study I mentioned found that tricyclic antidepressants like amitriptyline were among the worst offenders for dementia risk. Regular use increased dementia risk by nearly 60%, and the cognitive impairment starts immediately. Within weeks of starting amitriptyline, seniors develop memory problems, confusion, and difficulty with complex tasks. I've seen patients on amitriptyline who were diagnosed with early dementia. Their families were devastated. But when the amitriptyline was stopped, cognitive function returned within weeks. It wasn't dementia. It was drug-induced cognitive impairment that looked exactly like dementia. If you're taking amitriptyline for depression, newer antidepressants like SSRIs or SNRIs don't have anticholinergic effects. If you're taking it for nerve pain, medications like gabapentin or duloxetine are safer. If it's for migraines, there are multiple alternatives. There's no good reason for anyone over 65 to be on amitriptyline given the cognitive risks. Number 9. Oxybutynin. Oxybutynin is prescribed for overactive bladder and urinary incontinence. It's marketed under brand names like Ditropan, and while it can reduce urinary frequency and urgency, it does so by blocking acetylcholine receptors throughout your body, including your brain. The cognitive effects of oxybutynin in seniors are severe. A study in the Journal of the American Geriatric Society found that seniors taking oxybutynin performed significantly worse on memory tests than those not taking it. And brain imaging studies showed that oxybutynin use was associated with reduced brain volume, actual shrinkage of brain tissue. Here's the cruel irony. Seniors take oxybutynin to avoid the embarrassment and inconvenience of bladder control issues. But the medication causes cognitive impairment so severe that they lose independence anyway. They can't remember appointments. They get lost driving. They can't manage their finances. The medication solved one problem and created a far worse one. There are alternatives. Behavioral interventions like timed voiding and pelvic floor exercises can significantly improve bladder control without medication. Newer medications for overactive bladder like mirabegron work through different mechanisms and don't have the same cognitive effects. And in some cases, accepting some degree of urinary frequency is better than sacrificing your brain function. Number 8. Benzodiazepines. Benzodiazepines are medications prescribed for anxiety, sleep, and muscle spasms. Common ones include lorazepam, Ativan, diazepam, Valium, and alprazolam, Xanax. They work by enhancing GABA, a neurotransmitter that calms brain activity. And in seniors, they're associated with significantly increased dementia risk. Research published in the British Medical Journal found that benzodiazepine use for more than 3 months increased dementia risk by up to 51%, and the risk was dose-dependent. Higher doses and longer duration of use meant higher dementia risk. But beyond long-term dementia risk, benzodiazepines cause immediate cognitive impairment. They interfere with memory formation. They slow reaction time. They impair judgment. And in seniors, they cause a paradoxical effect. Instead of calming anxiety, they can cause confusion, agitation, and aggressive behavior. I've seen 75-year-old patients on lorazepam who became so confused and combative that their families thought they had advanced dementia. When the lorazepam was tapered off under medical supervision, the person returned to baseline cognitive function within weeks. The dementia disappeared because it was never dementia. It was benzodiazepine toxicity. If you're taking a benzodiazepine regularly, you need a tapering plan to stop it safely. Abrupt discontinuation can cause seizures. Work with your doctor to gradually reduce the dose over weeks or months. For anxiety, cognitive behavioral therapy, SSRIs or buspirone are safer long-term options. For sleep, addressing sleep hygiene and underlying causes is more effective than medicating the symptom. Number 7. Zolpidem. Zolpidem, sold as Ambien, is one of the most commonly prescribed sleep medications. It's supposed to help you fall asleep faster and stay asleep longer. But in seniors, Zolpidem causes profound cognitive impairment, dangerous behaviors, and significantly increased dementia risk. A comprehensive study in BMJ Open found that regular zolpidem use in adults over 65 was associated with a 78% increased risk of dementia. 78%. That's nearly double the risk. And the cognitive effects aren't just long-term, they're immediate. Zolpidem causes anterograde amnesia, meaning you can't form new memories while the drug is active. Seniors take zolpidem, get up in the middle of the night to use the bathroom, and have no memory of it in the morning. They have conversations, eat meals, even drive cars with no recollection afterward. This is terrifying for the individual and their family. Zolpidem also dramatically increases fall risk. It impairs balance and coordination. Seniors fall in the middle of the night, fracture hips, and end up in the hospital where they develop delirium and further cognitive decline. The medication meant to improve sleep quality destroys quality of life. There are better approaches to insomnia. Cognitive behavioral therapy for insomnia is more effective than any sleep medication and has lasting benefits. Low-dose trazodone or doxepin can improve sleep without the amnesia and fall risk of zolpidem, and addressing underlying causes like sleep apnea, restless legs, or pain provides more sustainable solutions. Number 6. First-generation antihistamines. Beyond diphenhydramine, there's an entire class of older antihistamines that are strongly anticholinergic and dangerous for senior brains. Chlorpheniramine, found in many cold and allergy medications, and hydroxyzine, prescribed for anxiety and itching, both cause significant cognitive impairment. These medications were developed in the 1950s, long before we understood their effects on the aging brain. They're still prescribed and sold over the counter today despite clear evidence of harm. The same research linking anticholinergic medications to dementia includes these first-generation antihistamines. What makes this particularly frustrating is that safer alternatives exist. Second-generation antihistamines like loratadine, cetirizine, and fexofenadine are just as effective for allergies, but don't cross the blood-brain barrier significantly. They don't cause drowsiness or cognitive impairment. Yet seniors continue taking the older, more dangerous versions because that's what they've always used, or because their doctor hasn't updated their prescribing practices. If you're taking any antihistamine that makes you drowsy or foggy, switch to a non-sedating alternative. Your allergy symptoms will be controlled just as well, and your brain will be protected. Number 5, promethazine. Promethazine is prescribed for nausea, motion sickness, and sometimes as a sleep aid. It's powerfully anticholinergic and causes severe cognitive impairment in seniors. I've seen cases where seniors were given promethazine for nausea after surgery and developed such profound confusion that they couldn't recognize their own children. The anticholinergic burden of promethazine is so high that it's on multiple lists of medications to avoid in older adults. The Beers criteria, a widely used guide for safe prescribing in seniors, specifically recommends against promethazine use in anyone over 65. Yet it's still prescribed, often in emergency rooms and hospitals for nausea. And once seniors are discharged on promethazine, they continue taking it at home, not realizing it's destroying their cognitive function. There are many safer alternatives for nausea. Ondansetron doesn't cross into the brain and has no cognitive effects. Ginger, either as tea or capsules, is remarkably effective for motion sickness and nausea without any side effects. And for most causes of nausea, treating the underlying problem is more effective than suppressing the symptom with medication. Number 4, tolterodine. Tolterodine is another medication for overactive bladder, similar to oxybutynin. It's marketed as having fewer side effects than oxybutynin, but in reality, it's still strongly anticholinergic and causes significant cognitive impairment in seniors. Research shows that tolterodine impairs memory, attention, and executive function. Brain imaging studies demonstrate reduced brain activity in regions critical for memory when patients are taking tolterodine. And the medication contributes to overall anticholinergic burden, especially problematic when combined with other anticholinergic medications. Many seniors are on multiple anticholinergic medications simultaneously. They're taking tolterodine for bladder control, diphenhydramine for sleep, and maybe an antihistamine for allergies. The effects are additive. Each medication alone might cause mild cognitive impairment. Together, they cause severe dementia-like symptoms, This is why comprehensive medication reviews are critical. Doctors need to assess total anticholinergic burden across all medications, not just evaluate each drug in isolation. Number 3. Paroxetine. Paroxetine is an SSRI antidepressant. Most SSRIs are relatively safe for cognitive function in seniors, but paroxetine is different. It has significant anticholinergic properties that other SSRIs lack, and this makes it particularly problematic for older adults. Studies comparing different antidepressants have consistently found that paroxetine causes more cognitive impairment in seniors than other SSRIs like sertraline, escitalopram, or citalopram. It impairs memory and increases confusion risk. If you're taking paroxetine for depression or anxiety, switching to a different SSRI can maintain the mental health benefits while eliminating the cognitive risks. There's no reason to stay on paroxetine when safer alternatives exist. Number 2. Cyclobenzaprine. Cyclobenzaprine is a muscle relaxant prescribed for back pain, neck pain, and muscle spasms. It's structurally similar to tricyclic antidepressants and has similarly strong anticholinergic effects. In seniors, it causes profound sedation, confusion, and memory impairment. The medication is meant to relax muscles, but it does so by suppressing central nervous system activity broadly. In an aging brain, this suppression goes beyond muscle relaxation. It impairs cognition, increases fall risk, and contributes to delirium. Cyclobenzaprine should almost never be used in anyone over 65. The Beers criteria explicitly recommends avoiding it. Yet it's still commonly prescribed for seniors with back pain, often by doctors who don't realize how dangerous it is in this population. For muscle spasms and pain, physical therapy, heat application, gentle stretching, and anti-inflammatory medications are safer and often more effective. If muscle relaxation is essential, medications like tizanidine or baclofen can be used cautiously at low doses, though they still carry risks in seniors. Number 1. Scopolamine. Scopolamine tops this list because it's one of the most anticholinergic substances known. It's used as a patch for motion sickness and nausea. And in seniors, it can cause complete disorientation, hallucinations, and severe amnesia. Scopolamine patches are often applied before surgeries to prevent post-operative nausea, but in older adults, they frequently cause post-operative delirium so severe that patients become completely confused, agitated, and unable to participate in their recovery. I've seen 70-year-old patients with scopolamine patches who didn't know where they were, couldn't recognize family, and experienced terrifying hallucinations. Removing the patch improved symptoms, but recovery took days because the medication continues absorbing through the skin for hours after removal. Scopolamine should be avoided entirely in anyone over 65. For motion sickness, ginger or ondansetron are far safer. For surgical nausea prevention, other antiemetics don't carry the same cognitive risks. What you must do right now: make a list of every medication you're taking. Include prescription, over-the-counter, and supplements. Go through this list and identify any of the 11 medications I've discussed. If you find any, schedule an appointment with your doctor specifically to discuss safer alternatives. Use this language: I've learned that this medication has strong anticholinergic effects and is associated with increased dementia risk in older adults. I'd like to discuss safer alternatives. This shows you're informed and that you expect your concerns to be taken seriously. If your doctor dismisses your concerns or insists the medication is necessary without explaining why alternatives won't work, get a second opinion. Your cognitive function is too important to compromise for medications that often have safer substitutes. Check your total anticholinergic burden. If you're taking more than one anticholinergic medication, the cognitive effects multiply. Even medications that individually might be tolerable become dangerous in combination. And educate your family. If you have cognitive changes, confusion, memory problems, or personality changes after starting a new medication, your family needs to recognize this as a potential medication side effect and advocate for you. Too often, these changes get dismissed as dementia when they're actually reversible drug effects. Not all cognitive decline in seniors is Alzheimer's disease or vascular dementia. A significant portion is medication-induced and completely reversible if caught early. The 11 medications I've revealed today are among the worst offenders, but they're not the only ones. The tragedy is how often medication-induced cognitive impairment gets misdiagnosed as dementia. The person is labeled with dementia, their medications are never reviewed, and they continue taking the drugs, destroying their brain. They deteriorate further, confirming everyone's belief that it's progressive dementia, when stopping the offending